Yes, now now I can, yeah. Hmm. Hmm. Right upper quadrant are the
Yes.
so umbilical, epigastrium, pubic, midline, yeah. And then we have is the right upper quadrant, left upper, sorry, right gastrium, left hypogastrium, right lower quadrant, left lower quadrant, and then right iliac and left iliac. So 9 quadrants. Hypochondrium, left hypochondrium, left hypochondrium, epigastric. Oh yes, yeah. Mm-hmm. Mm.
Midline.
Right. Mm. Mm. Transpyloric fin. Just below the ninth.
Yeah, continue.
Yeah, yeah, yeah. Yeah, they don't attach directly. Hmm. Okay, so jugular notch to the superior symphysis pubis. Pubic symphysis and jugular notch. That is a transpyloric fin. Mm, jugular notch and symphysis pubis.
Pubic
Yeah.
symphysis.
Mm.
Edison siblings. Siblings.
Yeah. So it is the ninth rib, and uh, the vertebrae will be L1, L2. Mm. Pylorus of the stomach. Pylorus of the stomach,
Pylorus of the
upper
stomach,
partition,
duodenal
duodenal
partition.
Okay. Okay.
Ninth beginning cervical bone, duodenal trunk. Trunk.
Pylorus of the stomach is the duodenal flexure, pyloric end of the pyloric flexure of the colon, splenic flexure of the colon, and root of the transverse mesocolon. Yeah. Right.
Neck of the pancreas.
Fundus of the gallbladder, neck of the pancreas.
L1.
L1.
Splenic fracture of
Mm.
costal cartilage. Costal cartilage.
Of the spinal cord.
Epidemic.
Mm. Yeah. L1 and then combination of the spinal cord and conus medullaris. Mm.
Hmm.
Pyloric veins.
Pylorus of the stomach, second part of the duodenum, duodenal flexure, then hepatic flexure of the colon, splenic flexure of the colon, root of the transverse mesocolon, fundus of the gallbladder, neck of the pancreas, hyla of the kidney, especially left one, on the hilum of the spleen, ninth costal cartilage, then termination of spinal cord and superior portion of the conus medullaris, origin of superior mesenteric artery. Okay, splenic vein join superior mesenteric vein to form portal vein. Are cisterna chyli, the beginning of the thoracic duct.
So, yeah. Why did you do this? Okay. So, fundus of the pylorus, yeah, pylorus of the stomach, pylorus of the stomach into duodenum, pylorus of the stomach due to jejunal flexure, um, and then hepatic flexure of the colon, splenic flexure of the colon, transverse mesocolon. Then we have is the neck of the pancreas, fundus of the gallbladder, splenic, what was that? Splenic hilum of the spleen and hilum of the hyla of the kidney, especially in the left one. Then ninth costal cartilage, then the termination of the spinal cord at L1 and upper portion of the conus medullaris, and the origin of the superior mesenteric artery. And the mesenteric vein, it joins the it forms the portal vein, the mesenteric veins. And mesenteric artery, origin of the superior mesenteric artery, SMA. And Kona, what was that? Kyla, cisterna chyli. Now, splenic veins join the mesenteric vein to form the portal vein. Yeah. T10. Internal thoracic artery. Subclavian artery. Subclavian are second. Aorta. Aorta. Yeah. Yeah. Common iliac artery. Abdominal aorta. Okay, superficial circumflex iliac and superficial epigastrium. Okay. Iliac-violent artery. Yeah. 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 Yes. Tight pants. That is natural. So why is it related to the hernia? Why is it coming under the hernia? Injuries. Okay. 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 Ilioinguinal. Yeah.
Yeah.
Yeah. I will. It's just a oven. Sorry. Superficial inguinal across below the umbilicus. Okay. It goes to axillary lymph nodes. Okay. Okay. Below the umbilicus, it goes to. Yeah. it happened. Mm, 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 mm. Yeah. Mm, 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 mm. Yeah. Here's where like spine. There is some background noise or like a background disturbance. I don't know. It's not on the my end though. Yeah, I think now it's all right. Yeah. Mm. Mm-hmm. Mm-hmm. Mm. Okay. Mm, mm, mm. Okay. Mm, mm, mm. Femoral vein.
Inguinal.
Adductor longus, sartorius, and superficial inguinal ligament. Okay, so nerve, femoral artery, femoral vein, and lymph nodes. Yeah, yeah. I do lateral to medial is that, and then there is a femoral canal. Yeah. Excellent. Mm-hmm.
And
Mm-hmm.
transverse.
Mm-hmm. Rectus abdominis. Mm-hmm. Yeah. Yeah. Mm-hmm.
superficial.
Transfer. Yeah. In campus, Scarpa, external, internal transfers.
Extraperitoneal.
So, doctor, where is the rectus abdominis? Okay. Okay. Extraperitoneal fat. Transversus. Yeah, transversus fascia and brachioperitoneum. Peritoneal cavity, then the parietal cavity, visceral peritoneum. Where? Sorry? Yeah. Skin.
Camper fascia.
Carpa
Scarpa
fascia.
fascia.
Campus fascia. Campus fascia.
Muscles.
Carpa fascia.
External, internal.
External
Transverse.
oblique. Internal oblique. Transverse abdominis.
Abdomen.
Extraperitoneal fat.
Transverse.
Then, yeah, transverse abdominis extraperitoneal.
Transversal
Yeah.
fascia. Extraperitoneal fat.
Okay. Okay. Trans. Skin, carpa, campus fascia, carpa fascia, external oblique, internal oblique, transverse abdominis, transverse transversus fascia, extraperitoneal fat, and then parietal.
Yeah. Skin, Camper fascia, Scarpa fascia, then external oblique muscle, internal oblique muscle, transverse abdominis muscle, transversalis fascia, extraperitoneal fat, then parietal peritoneum. Rectus abdominis.
Mm-hmm. Mm-hmm. Inferior medially downward. Inferior medial. Superior medial. Rectus abdominis. And tendinous intersections. And linea semilunaris is in the margin. Linea alba center. It forms the edges, isn't it? Is it? Yeah. External oblique, external internal oblique, transversus. Mm-hmm. Mm-hmm. Rectus abdominis. Mm. Okay. Mm-hmm. Yeah. Linea alba. Internal, external oblique. And
Internal oblique. Internal.
Transverse abdominis.
And posterior part of internal. Internal.
there will be
epimedullary.
no posterior rectus sheath, because all three they pass to the anterior of the rectus abdominis. Intersections. Okay. Z-part process of the sternum. Postural cartilage. Midline of what? Pubic symphysis and okay.
Yeah.
Okay, we can continue. Okay, so we were saying the midline, we have median umbilical ligament. Lateral to this midline, we have medial. I remember it is lateral to median, so it is L, medial. And the one who is in the middle, that is N, median. Median, then lateral. And this is lateral. You can hear me or no?
Yeah, yeah.
Okay, okay.
Yes, sir, we can hear you.
Okay, so this is median umbilical ligament, which is called urachus. Just remember this word. Just this information is enough. No need details. Median umbilical ligament. This is actually the urachus. This is the remnant.
Urachus, yes.
Urachus. Yeah, it is in the midline. Then medial. Medial. Remember this word L. This al. Medial umbilical ligament. This is fibrous part of the umbilical artery. This is a direct question. Medial umbilical ligament is the remnant of which structure? Umbilical artery. Fibrous part of the umbilical.
Medial umbilical ligament. Yes, umbilical artery.
This is umbilical artery. And then lateral umbilical fold. This is inferior epigastric vessel. Lateral umbilical fold, inferior epigastric vessel. Again, first is median umbilical ligament. This is urachus. Then median. Median is umbilical artery, fibrous part of the umbilical artery, and lateral inferior epigastric vessel. Inferior epigastric vessel. Yeah. Read this thing. It is written here. You just can read this one. Now, this is exam question. Not only part A. This is part B, part C, D, E, F, G, everything. Diaphragm is very important. Thorax and abdomen, which allows some structure to pass from thorax to abdomen through some opening. The openings are in different level at thoracic 8, thoracic 10, and thoracic 12. Thoracic 8, vena cava opening, thoracic 10, esophageal, and thoracic 12, aortic. Now, exam question, they ask mainly about their vertebral level, their cava opening. This is vena cava opening. We have esophageal opening. We have aortic opening. 8, 10, and 12 serially. First 8, VOA. I remember it like VOA, 8, 10, 12. VOA. V for vein. Which vein? Mainly inferior vena cava. Okay. T8. T8. This is vena cava opening. Vena cava opening, T8. It remains in the central tendon of the diaphragm. And structure passing through inferior vena cava, right phrenic nerve. Very, 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 very important. Right phrenic nerve, right phrenic nerve, right phrenic nerve.
Right phrenic nerve and vena cava.
And vena cava. Vena cava, they don't ask about vena cava because vena cava opening, everyone knows inferior vena cava will go. But they forget about right phrenic nerve. They give different options like left phrenic nerve, right vagus nerve, to confuse. remember right phrenic nerve again. This is vena cava opening at T8 level, main structure inferior vena cava along with right phrenic nerve.
Right
So
phrenic
what?
nerve.
So what about left phrenic nerve? Left phrenic nerve pass through which opening? Answer is no opening. Left phrenic nerve, they don't cross through any opening. They directly fires the diaphragm. Okay, directly they fires the diaphragm and they supply to the inferior surface of the diaphragm. So vena cava opening finish. Now at thoracic 10 level we have
Esophageal hiatus.
esophageal opening. Esophageal opening or esophageal hiatus. It locates in the right crus of the diaphragm. Diaphragm has two crus, right crus and left crus. Esophageal opening will remain in the right crus of the diaphragm. Any one of you, if you have participated in sleeve gastrectomy or gastric bypass, then you must have seen this crus on the diaphragm. And this is a very tricky part for the surgeon, very tricky part to dissect this part properly. Main problem of this vagus nerve, because it remains just same location. Okay, so esophageal opening remains at T10 in the right crus of the diaphragm. Their main component is esophagus and vagus. Esophagus, vagus, esophagus, vagus, esophagus, vagus, esophagus, vagus. They are very close friends. Esophagus and vagus.
And vagus.
Yes, and vagus is the ultimate boss, nerve of our abdomen. Not abdomen, thorax also. When we will read thorax, we will see the power of vagus. We can make a short film, power of vagus. Okay, so thoracic 10, it has esophagus and vagus. Which vagus? No need to differentiate. Okay. Actually, vagus nerve plexus remains there. Just remember trunk. Vagus nerve. Trunk. Yeah. Vagal trunk. Now, thoracic 12 level. This is for aorta. T12 for aortic opening behind median arcuate ligament. Median arcuate ligament. Remember? Yeah, median arcuate ligament. Contents are aorta. Which aorta? Descending thoracic aorta. Descending thoracic aorta. Yeah. Descending thoracic aorta. Azygous vein, thoracic duct. Either they will ask from aortic opening or vena cava opening, but be 100% sure. One question will be here, from here.
Oh.
Okay.
Descending thoracic aorta is azygous vein and thoracic duct.
I remember it as like KAT. KAT 12. Means T12. T12 is their location. A for aorta and A for azygous. KAT 12. Now, their origin. Diaphragm origin, sternal part, costal part, and vertebral part.
Lumbar, yeah.
Sternal part from xiphoid process of the sternum. Costal part from the inner surface of the lower 6 costal cartilage.
6 costal cartilages.
Inner surface. Lower 6 costal cartilage. And vertebral part in right side from number 1 to 3 and left side number 1 and 2. Esophageal opening coming from which side? Which?
T10.
Yeah, T10. And their location will be in the right crus. Right crus. Right crus. Lumbar 1, 2, 3 level vertebra. Insertion, diaphragm insert into central tendon, central aponeurotic tendon, central aponeurotic tendon. All the three parts. They insert into central aponeurotic tendon. Their action, inspiration and forced expiration. Inspiration and forced expiration, and they are innervated by phrenic nerve.
Phrenic nerves.
Cervical 3, 4, 5. 3, 4, 5 keeps the diaphragm alive. Cervical 3, 4, 5. 3, 4, 5 keeps the diaphragm alive. Kind of mnemonic you can remember. And blood supply by inferior phrenic artery. Inferior phrenic artery. Inferior phrenic artery. Now a cross look, you can have a look. This is diaphragm. This is right crus. Right crus coming from lumbar 3, lumbar 2, lumbar 1.
1, 2, 3.
Right? 1, 2, 3. And left crus, lumbar only 2 and 1. This is vena cava opening. With vena cava opening, we have which nerve?
We have the right phrenic nerve.
Right phrenic nerve. Now this is esophagus. With esophagus, what do we have?
We have vagal trunk.
Vagal trunk. Esophagus, vagus. Esophagus, vagus. And then we have aortic. We have aorta.
Descending thoracic aorta, thoracic duct, and azygous vein.
Azygous vein. Yeah. You both are very sharp.
Less than you.
Very good. Okay, again have a gross look, just to have a photographic idea how this structures. Right phrenic nerve coming down, 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 and this is vena cava. With this vena cava, it is going down. It is not very important, just to have a gross look. And left phrenic nerve. Let's see, left phrenic nerve, it is going down and directly it is piercing the diaphragm, not with any opening. This is esophageal hiatus here, and we have left vagus nerve. If you want to be very specific, remember left vagus nerve, but overall, if you say vagal trunk, that is also okay. Left vagus nerve. Now this is my favorite topic. Inguinal canal. Inguinal canal, if you remember the previous picture of anterior abdominal wall, then this is very easy. I took this picture again. External oblique, internal oblique, transversus abdominis, right? These three were the muscle there, remember? So boundaries of the inguinal canal, inguinal canal, inguinal canal, inguinal canal boundary. First, anterior wall. Anterior means the anterior, the first wall. External oblique aponeurosis. This is the first layer of the anterior formed by the external oblique aponeurosis. Don't remember this picture. Mainly we have to remember this kind of picture, but this one I took only to correlate with the previous structures. So anterior wall by external oblique aponeurosis, then posterior wall by its posterior wall. This picture's posterior wall, that was transversalis fascia. Transversalis fascia. Here transversus abdominis muscle, then will be the transversalis fascia. So posterior wall will be by transversalis fascia. Transversalis fascia. Now what are the structures that remain in between? We have internal oblique and transversus abdominis, right? Pending two structure is internal oblique and transversus abdominis. These two, internal oblique and transversus abdominis muscle, form the roof of inguinal canal. Yeah. Now easy, very easy. And floor is just like the basement where the floor is inguinal ligament. Inguinal ligament actually the special part of the external oblique. We have seen in the picture, right? External oblique, when it is coming down and joining with anterior superior iliac spine and pubic symphysis, then its name becoming inguinal ligament. Actually, this is the aponeurotic part of the external oblique. Same thing. So now again, considering this picture, if we remember anterior wall, which was formed by a muscle, external oblique muscle, this external oblique forming the anterior wall of the inguinal canal, and posterior wall by the tough fascia, transversalis fascia, and in between two structure, internal oblique, transversus abdominis, forming the roof. And floor is by inguinal ligament. This is actually the inguinal canal. What is canal? Canal.
The structures to pass through it.
Yes. It is a tube-like structure, like this canal. Like we have water canal or tunnel, like this. So they have an anterior wall, they have a posterior wall, they have a basement or the floor, and they have a roof like the covering. So anterior wall will remain where? Anteriorly. So now anterior wall is forming by the external oblique aponeurosis, and this is actually the superficial ring. Very nice. Before, when I was reading this one, I spent a lot of time to absorb it. Yeah, even in MBBS level also it was there, and I don't think I understood that time. But later on it became very easy. So anterior wall, remember with a original human body. This is a human body, okay? And here is the canal or tunnel. Tunnel is starting from here. This is the deep side, and it is opening here. This is the superficial side. It is a tunnel, right, like this. Okay. See, this is anterior wall, and it is forming by this structure. And what is this structure? External. This is the muscular part. External oblique muscle. This is muscle, and practically when it is coming anteriorly, it is becoming the aponeurotic part, and this aponeurotic part forming the anterior wall of the inguinal canal, and go the deep side. This is external oblique, internal oblique, transversus abdominis. Then we have transversalis fascia. And yes, and this transversalis fascia is forming the posterior wall. Now we need to have a basement. So this basement is forming by the inguinal ligament, and now we need a roof or covering. This covering is forming by these two muscles, one this muscle, one this muscle. So what is the name? Internal oblique muscle, transversus abdominis muscle. See, here they are forming their roof. So this is the superficial ring of the inguinal ligament, which is formed by the external oblique aponeurosis, and deep ring, which is formed by the transversalis fascia. It is easy, difficult, I don't know. Now you can read this part, then you will understand easily. Inguinal ligament, deep ring, superficial ring, inguinal canal. Through this canal, inguinal canal, if any hernia occurs, it will be which type of hernia?
Inguinal hernia.
Very good. This will be the inguinal hernia. This is direct hernia or indirect hernia?
It can be both indirect and direct hernias. The indirect, it passes lateral through the deep inguinal ring, and the direct, it is medial.
No. Question was
Hasselbalch
if
triangle.
if hernia occurs through this canal, then this will be which type of hernia?
Direct.
I think it will be indirect.
Yeah, it will be indirect. It will be indirect because it is first entering into the deep ring, then it is coming to the superficial ring, then it is
Superficial.
coming outside. So it is passing through a long way. Indirectly, they are coming out of the abdomen. Yeah. So this is indirect inguinal hernia. And if hernia occurs directly through the abdominal wall, that will be the direct hernia. We will see. And that will happen through the weak point of the abdominal wall called Hasselbalch triangle.
Hasselbalch triangle. Yeah.
Now, content of the inguinal canal, very important. In case of male, inguinal canal contains spermatic cord and ilioinguinal nerve. It is common. Ilioinguinal nerve is common for both male and female. Ilioinguinal nerve common for both male and female. In case of male, spermatic cord; in female, just the replacement of spermatic cord is a round ligament of the uterus. Okay, spermatic cord; in female, round ligament of uterus.
Female
And
round ligament of uterus and
ilioinguinal nerve. As it passes through the canal, the spermatic cord has the covering ECI, external spermatic fascia, cremasteric fascia, and internal spermatic fascia. External spermatic fascia, internal spermatic fascia, and in between we have cremasteric fascia. These are the three layers of the spermatic cord. This is spermatic cord and it is covered by three fascia. What is the name of this fascia? First is external
spermatic fascia, cremasteric fascia, and internal spermatic fascia.
Spermatic fascia, yes. Again, the same picture we have seen, and here they are saying about this fascia here. External spermatic fascia externally. Then we have cremasteric fascia. It is not seen here. A cremasteric muscle and the fascia here. Okay, this one. And then we have internal spermatic fascia. So number 1 layer, number 2 layer, number 3 layer. Dr. Sanjita, what are the layer of the spermatic cord while passing through the inguinal canal?
Layer of spermatic cord has external spermatic fascia, cremasteric fascia, and internal spermatic fascia.
Yes. Now we got Hasselbalch triangle. This is a big muscle. This is pubic symphysis. So here we have the muscle. This muscle is which muscle? This one?
External oblique?
Rheumatoid arthritis, RA. Not RA. It is rectus abdominis muscle.
Oh,
Okay.
is it? Oh, sorry. Yeah.
The rectus abdominis muscle. And see, this is the arcuate line. This is the arcuate line. Arcuate line. This is arcuate line. Below the arcuate line, there will be no posterior wall. Yeah, no posterior wall of rectus shape. Only the anterior, and this is that anterior wall. Okay. So This is rectus abdominis muscle lateral border, right? Lateral border.
Rectus abdominis is lateral border, yeah.
This is inguinal ligament. This is anterior superior spine, anterior pubic tubercle. This is the ligament, inguinal ligament. So we got two border. One border we got like this, forming by the lateral border of the rectus abdominis. Another border we got inferiorly by inguinal ligament. So we have two border. Now this upper border we need to form a triangle, and this border is formed by this is inferior epigastric vessel. Inferior epigastric vessel. Inferior
So where
epigastric
was the
vessel.
medial lateral?
It is
Rectus
called
abdominis
medial.
forms the lateral or medial?
You first, if you remember, I mean, understand, then you have your explanation. If you compare, if you describe the triangle, then you can say its relation. Suppose this is the triangle. Now, in relation to this, if you try to describe this one, what you will say? This is the lateral border of rectus abdominis, forming the medial wall of the Hasselbalch triangle.
Wall of the Hasselbalch triangle, right?
Yes.
And then the lateral boundary is formed by the inferior epigastric vessels, and then the inferior boundary is formed by the inguinal ligament.
Yeah. It is easy. We have this, see this epigastric vessel. Epigastric vessel are coming from the external iliac vessel. Epigastric vessel, we have inferior epigastric vein, inferior epigastric artery. Inferior epigastric vein coming from the external iliac vein, and inferior epigastric artery coming from external iliac artery. This triangle is called Hasselbalch triangle.
Hasselbalch triangle.
Again, very nice picture. They explained about direct and indirect already. We see. This is Hasselbalch triangle. We have seen the boundary by rectus abdominis, lateral margin of rectus abdominis, inguinal ligament, and inferior epigastric vessel. If any hernia occurs directly through this weak point, it will be the direct inguinal hernia. And if it occurs through the inguinal canal, which start from the deep inguinal ring, that will be the indirect. Yes, it enter into the deep ring, it passes through the canal, it coming out through the superficial ring. What is the content of the inguinal canal in case of female?
Round ligament and ilioinguinal nerve.
Round ligament of what? Uterus or ovary?
Uterus.
Direct, indirect. Indirect inguinal hernia means it is occurring through inguinal canal, right?
The inguinal canal, the superficial inguinal ring.
Indirect inguinal hernia represents 80% in children. So mainly indirect inguinal hernia is congenital. Okay. Remember, indirect inguinal hernia mainly congenital. Mainly congenital. For pediatric hernias, a herniatomy without mesh is sufficient as decay surgery. Yeah. Below 1 year, repair it urgently. Above 1 year, repair it electively.
So my question is, the indirect inguinal hernia cannot happen in the adults?
Adult? 20% case. Have to remember these definitions here. Litters hernia. Litters hernia. What is litters hernia? See, this is pouch. Meckel's diverticulum. This is Meckel's diverticulum. During appendectomy, usually surgeon explore small intestine to look for any outpouching like this. Okay, and they actually look for Meckel's diverticulum. Okay, so if any hernia content is Meckel's diverticulum, it is called Litter's hernia.
Litter's hernia.
Okay. If containing only one side of the bowel wall, which may become strangulated, it is called Richter's hernia. Richter's hernia. You can see all the picture in Google. Okay. But the definition I have to remember: Richter's hernia. Epigastric hernia through the epigastric region of the linea alba requires hernia repair. Incisional hernia through the previous scar, through the weakness in the abdominal wall, a site of the previous surgery. Spigelian hernia through the linea semilunaris. You say, you remember? I told a special type of hernia occurs. This is called Spigelian hernia, and this is exam question. Through the linea semilunaris, repair due to the risk of strangulation. Spigelian hernia. Then paraumbilical hernia and umbilical hernia. If it is umbilical hernia, there will be similar terms. One is gastrochiasis, another one is exomphalus. Okay. Gastrochiasis, isolated abnormality. Bowel lies outside the abdominal wall through the defect located right to the umbilicus. If it is right to the umbilicus and bowel is outside of the abdominal wall, it is called gastrochiasis. It occurs right to umbilicus. And exomphalus, it actually occurs through the umbilicus. Exomphalus. Liver and gut remain covered with membranous sac connected to the umbilical cord. This exomphalus occurs through the umbilicus and gastrochiasis right to the umbilicus. Exomphalus again has two varieties. One is minor if defect is less than 5 cm and major if defect is more than 5 cm. Okay, so exomphalus and omphalocele, same thing. Exomphalus and omphalocele. So they gave the name minor omphalocele or minor exomphalus, major exomphalus, or minor omphalocele, major omphalocele. So omphalocele through the central umbilicus and gastrochiasis right to the umbilicus. And which is central to the umbilicus. If anything coming through the umbilicus, there will be a covering, sac or covering. Always there will be a covering. Okay. And it occurs more in female through the umbilicus. Associated abnormalities, frequent heart abnormalities, and gastrochiasis, right paraumbilical, sac never present, and it is both in male and female, and usually they don't have any other abnormalities, just paraumbilical hernia, the gut came out of the abdomen. Again, if we put them back, it will be okay, but in omphalocele there will be some cardiac abnormality or other abnormality. We can conclude here tonight, I think. here, and abdomen is very
So
important.
it's just the hernias that we have here, till the hernias, types of the hernias.
Yeah, types of the hernia. We finished up to
Yeah,
page
can you
number.
explain? I am just confused. What is the paraumbilical and umbilical then?
Para-umbilical means not directly through the umbilicus, but side of the umbilicus, around umbilicus. Suppose this is umbilicus, this is umbilical. If
Yeah.
hernia occurs through this, during birth, this will be omphalocele. If it is less than 5 centimeter, minor. If it is more than 5 centimeter, major omphalocele. But if hernia occurs through here, suppose here,
Yeah.
then it will be exomphalus, and it will be very large. All the bowel will be outside of the abdomen, and there will be no covering. You can see the liver here, you can see spleen here, everything outside.
This one is examphilus.
This one is exomphalus. No. Gastrocriasis.
No, it's
This is gastrocriasis.
just
Exomphalus and
creases.
omphalocele both are same.
Same.
Yeah. Scrotal and testicular anatomy. If you can read this one. Actually, there is some similarities.
First finished that.
Yeah, abdomen is important, and you have to remember everything. Don't be upset. You will get back to Titanic again.
So we will revise till now, right? And then
Yeah.
tomorrow we can start the story. What do you say?
Yeah, tomorrow we will start from scrotal
So
anatomy.
tonight we will just finish that much we studied today.
Yeah. Don't forget about inguinal canal. This is my favorite topic. If you make mistake, I will be very angry. Inguinal canal, inguinal ligament, their content, their everything. Okay, then good night and prepare properly. Tomorrow morning time, if both of you are free, we can have a session. Abdomen, it will take 2 or 3 days. Okay.
Yeah. As long as we do good, then it's no problem to wait 3 days, isn't it? As long as we
Yeah.
go through it thoroughly and prepare the questions and all.
Especially
Well,
anatomy. If you read the lecture file properly, MRCS becomes easy.
But Dr. Adhikary, one of my colleagues was telling me that they changed the questions or something like that, that they put new questions, and is it true?
Tell him to give the question.
I don't know.
No, doctor. They will suppose before in past test or in records, you will see transpyloric plane passes through upper border of which vertebra. And now if they give transpyloric plane passes through lower border of which vertebra? Do you find any difference in these two questions? Same question. And before they used to give which of the following structure is not in the transpyloric plane. They gave hilum of the lung, hilum of the kidney, hilum of the liver, hilum of the spleen. So definitely hilum of the lung is not in that level. If you read thoroughly this, you will be able to answer. Some of the doctors, not some of the many doctors, they cleared MRCS without studying any of this thing. They just studied past test and the recall. And their luck also supported them, and exam question was also easy on that particular session. They clearly passed the exam. But now they need a little details.
Maybe it's 3 to 4 years ago. Like
Yeah,
my lots of friends they passed MRCS part one easily. They said just they read the
studied
only
some past
questions.
test. Yeah,
Yeah.
but I don't recommend because all these things. Just 1 second, I will show you one of my part B paper. I can say I'm well prepared for part B than part A, because for part B I prepared everything with a lot of time.
Mm.
Whatever we are studying now is all will again repeat in part B. All, especially anatomy. Okay, no problem. We will see in another day. But your task will be for anatomy. Don't skip whatever the topic we are discussing. Please try to read everything.
Yeah.
Even if you can read more, most welcome. But these are the must topic to study. And most welcome, doctor. If your any colleague can provide you some other extra material, can study, no problem. The more you study, more you learn. Okay, but
Yeah.
till now, after
This is the
during,
basic.
yeah, this is the basic, and this is mandatory. You have to. Without this, you cannot go to the exam hall.
Mm.
While I was in your situation, when I just started, I took initial 3 to 6 months to understand what I need to read.
Yes.
You are lucky. From the day one, you know
Yeah.
what to study, what not to study.
No,
Okay.
doctor, I have been trying to prepare it for the last so many months. But I told you the story, isn't it? Like, that I don't know how to, where to start and where to end. Because,
Mhm.
the book itself, the MRCS book, yeah, it's so
Mhm.
expensive and it
Mhm.
has no explanation in it. Okay, it is just the headings and like the topics and
Mhm.
like one or two diagrams. That's it. The MRCS IB book that the people call it, isn't it?
Yeah.
So yeah, I was also stuck. I got lucky that I found you, and then your knowledge is fresh as well, and you have all this thing to give us the basics, and then of course we have to build by ourselves through other resources maybe. But I had no idea that what to study because general surgery and anatomy is so expensive. The more
Mhm.
detail you go into, the more you dig into, the more expensive it becomes.
Yeah.
But MRCS part A, I think it's more study the topics
Yeah.
that they test again and again. I think that is more important than just blind study, open the book and do it from A to Z. I don't think so. That is the, yeah.
So don't worry. While I was preparing, I tried to collect